Oh, hello. Yes. Good afternoon. Good afternoon. I'm really excited to be here. Marie-Louise, thank you for the invitation. And I especially like this topic. I'm an educator. I am the Director of Medical Student Education at my institution at Vanderbilt Eye Institute in Nashville, Tennessee. Previous to that, I was the Associate Residency Director for 8 years at Vanderbilt, so I'm very invested in where ophthalmology training is headed, especially in the US. So this topic is apropos. And I don't have any financial interest or conflicts, except that I have interest for sure in making sure our ophthalmology trainees in the US come out competent and healthy too. So I'm going to cover these 5 topics regarding where the U.S. training programs are headed. We're going to talk about how we have so little time and the newest change, which is integrated internships. I'll talk about data-driven curriculum, integrating interactive education, and I'll also talk about our increase in culture of patient safety through quality improvement projects. And then physician well-being is a very important topic to us in training. So due to the expansion of medical knowledge in ophthalmology, the expansion of surgical procedures, new techniques, it's so hard to fit everything into our 3 years of residency training. So we talked about, for several years, deliberated on the possibility of expanding our ophthalmology training. So go from 3 years to 4 years. And you know that's not going to be a popular choice for a lot of our trainees to make training longer. So we looked at it and we looked at it and we found a creative way to get more ophthalmology inside our residency training. So new, starting in 2021, this just came out a few months ago. The ACGME, which is our accrediting board, is asking us to create integrated internships. So let me talk about how we traditionally have done it. So traditional US training looks like this: 4 years of medical school. Then you go into an internship, which is 12 months, and you're technically a free agent. I can do an internship in California, and then I can do training in Tennessee. Or I can do an internship at Harvard in Massachusetts, and then I can go to Texas for my training. So you're a free agent. You can do that separately. And during your 12 months of internship, you can study any of the topics in internal medicine or primarily general surgery, or what we call a transitional year, which is a little bit of a mixture of both with a lot of electives. And you would be practicing like this gentleman here, who is writing hypertensive medication prescriptions and managing chest pain. That's an internship. Then you go on to do your 3 years of residency, and your 3 years or 36 months of residency can be at that other location, like I said. So then you complete your training, and then you move on, take your boards. And that's our traditional training. But in 2 years from now, we are mandating what we're calling an integrated internship. And that now will look like this: 4 years of medical school, 9 months of internship. And this is a creative way of finding more efficient training in that intern year. Yes, we do believe that practicing as a general medicine physician is important. We need to have that foundation. But some of those rotations and electives that they experience in their internship isn't always directly related to the skill set of an ophthalmologist. So we creatively are finding 3 months in that intern year to take it away and put it into ophthalmology. And fortunately, I think, when you do this integrated internship, you'll be doing it at the same institution. So no flying to Texas and going to another state. It will be all at the same institution. So you start off as your intern year at the institution that you are training for ophthalmology. So again, you can choose internal medicine, general surgery, or transitional year. Then you have your 3 months of ophthalmology inside that 1 year. Then you move on to do your traditional 36 months of ophthalmology residency. And just to illustrate it another way, you can see that, I'm going to use this pointer here, you can see that you still end at the same time. So the training length has not lengthened. However, we're doing a little less of this more general medicine or general surgery internship, and a little, a little less of that in this figure. So what we get is 12 additional weeks of ophthalmology. And as educators, we are super excited about that, because why wouldn't we want to teach you more of that versus more of ICU, intensive care knowledge? We really want you to know more about the new surgical techniques and the different things we want to include in our curriculum. So let me tell you about some of the other benefits from this, not just added content. you actually, since you are showing up on day one to your institution, you get to learn the hospital system. You get to learn the program culture. You get to learn about their electronic medical records and start using it right away. So you don't have that steep learning curve of, I have to learn how to use their medical records and how to report to these people and learn ophthalmology at the same time. You don't have that stress. So at the beginning of your internship, you get to just ease your way into the system. You get to learn more about your program faculty and peers. And then, of course, you learn more basic skills sooner. So we're allowing the skill set to be shifted earlier. So now in their intern year, they're going to be more facile with the slit lamp, with indirect ophthalmoscopy, with refraction and retinoscopy and keratometry and gonioscopy and everything. So the exposure is going to be very positive. And that'll allow programs to also find time at the end of that 36 months. Now that everything's shifted, maybe we can do mini fellowships. So there are a lot of residents who want to spend a little more time in glaucoma, or a little more time getting ready for fellowship, or maybe spending more time learning more about whether or not they want to apply for oculoplastics. So this finds room in the curriculum. And then if there are residents that are struggling, well, then they'll be able to repeat a couple rotations and get on their feet. So that's another benefit. And my belief of this is that it should improve physician wellness overall. I think it'll have an indirect benefit because then you've reduced anxiety, you've reduced isolation, you are now in with your crowd, you're there, and you're starting to develop your social relationships much sooner. Because if you think about doing an internship in Texas and then you move to Boston, you have to make new friends, you have to get acclimated. That does take a lot of time. The next topic is improving on our data-driven curriculum. So we are very data-driven and data-heavy, and we like to let data inform us on how our education programs are doing. So in 2012 or so is when the ACGME, again, our accrediting body, had printed and published our milestones. And if you're not familiar with the US milestones, the milestones are basically taking apart what an ophthalmologist needs to do or know, making them achievable steps, and then giving you an opportunity to have it written out, described, and you are able to assess your trainees based on their abilities to achieve those steps. So it allows for meaningful assessments. We can look at descriptively how well a resident is able to do a particular step in a procedure, or how well they speak to patients. And then by using these, we then look to see at our program how well we're doing as a whole. So this is just an example. It's kind of small up there, but I have a big one coming up. Non-surgical therapy, I'll just go over one of them. Level 3, describes indications for oral and IV therapy and recognizes possible racial, gender, and genomic differences in outcome of medical therapy. So someone may come in already being able to do level 3. But we want to see them progress. So then there's a level 4 to be looking forward to. And I like to use this also as a tool for the learners themselves. They should be able to look at this and say, this is what I need to strive for. So the milestones are a very positive change that has happened to our curriculum. Here's an example of cornea. So I blew this up a little bit bigger for people to see, and I also put it on a PDF or a QR code. If you haven't seen these milestones or have implemented any of the information in there, go ahead and turn your smartphone on if you've got one, turn it on to camera, and just point it at the QR code, and you should be able to grab that PDF that I linked it to. You can have that. So this is the appendix to our ACGME milestones. The appendix has the different specialties listed as the different surgical techniques you should be able to learn. I'm only showing cornea. I'm a retina specialist. I decided not to do the retina one, but you can find retina, plastics, cornea, glaucoma, neuro. You can find them all. So this is just an example. But if you look at the levels, level 2, you should be able to perform a corneal foreign body removal at slit lamp. A level 3, you should be able to perform suture removal at slit lamp. Level 4, you should be able to perform an LRI, or limbal relaxing incision, as part of your cataract surgery. So as our learners progress through this stage, we can see how well they're able to achieve what we want them to achieve by the end of graduation. And all that to say is that all of those things are being updated. So because it's been around 6 to 7 years, the ACGME and many ophthalmologists that are on this committee are looking at the data to see how helpful has it been, is it accurate, is it going to inform us of what other milestones need to come along, or how can we modify the description so that they really are true to life. So that'll give us more meaningful feedback. And then one more thing about milestones and surgical minimums is that these numbers are also being evaluated. So this is not always data-driven. Actually, these numbers are somewhat, I'm not sure if they were just decided upon, but some of them are also are truly data-driven from like the cataract surgery minimums. So a study was shown that no more than 80 surgical experiences of primary cataract surgeries made their competency any better. So that minimum is 86. And then there are some other numbers here you can see that there are single digits, and those are somewhat random. So they're going to be looking at those numbers and looking to see how we can improve that. We're going to be improving the way we do interactive education. So I'll be showing you some examples of how we're using interactive modules for surgical simulation. Coming soon is the Cataract Master, which is not yet available for prime time, but I'll show that real quick. And we are implementing virtual reality and 3D training. So if you go to the aao.org and you go to the residence section, or if you go into the search function and just look for some of these, just type in surgical simulation or training modules, you'll see some of these modules are available. So some of you may already know that the pathology module is there, and that is free for everybody, even if you don't have a membership. Then we have the ROP case-based training module, where it gives you a case-based scenario. You have to look at the picture and identify what type of ROP this is, and would you initiate training treatment. Then there's the retinoscopy simulator, where it can show you the different streaks, and you have to be able to assess the measurements. And then also measuring strabismus, and we showed this in the Yo Lounge if some of you were there yesterday. So these are all available. These are all free without a membership, but these are ways to be more interactive and finding multimodal ways to teach. So the Cataract Master is coming soon. So you will not see this on the aao.org yet. This was invented by Bonnie Henderson and John Lovenstein at Harvard. And this is more of a choose-your-own-adventure simulation for cataract surgery. So it'll give you different scenarios, real-life scenarios that you might come into contact with. And as you go through them, you have to make these decisions. And that leads to another decision, that leads to another decision. So it really applies your cognitive decision-making ability. So coming soon, I would look for that. I think it's really exciting. And then, of course, you know, there's heads-up display in 3D surgery. So it doesn't make any sense to have all this without our residents having practiced that. And so a lot of the 3D heads-up microscopes are coming to training programs so that we can go from patient experiences to wet lab to dry lab into 3D labs. And lastly, well, I think this is second to last, is quality improvement. So quality improvement projects are now part of our ACGME requirements for graduation. And this is important because it allows our residents to implement two areas of the core competencies, and that is systems-based practice and problem-based learning and improvement. So basically looking at your system, looking at how you operate within your clinic, how you operate within your OR, how you operate within the hospital system, what errors might be occurring, what protocols may need to be put in place for patient safety, medication errors, or maybe even looking at whether or not there's communication breakdown. So it really allows the resident to dissect that and to be able to develop a quality improvement project around these learning points. And overall, the department's going to improve in building a culture of safety, so it's all good for patients. And lastly is physician well-being. As we know that over 50% of medical students and residents are depressed, and that leads to burnout, and our suicide rate is increasing amongst our healthcare providers. So the ACGME made this a very important priority to include physician well-being in our residencies. So ophthalmology training is now including how to train yourself to be healthier, how to make healthy decisions, sleep better, but also the program is mandated to ensure protected time with patients, so you're not rushed through your patient visits, minimizing non-physician obligations, ensuring an environment free of harassment and coercion, and providing residents and fellows with time for personal, medical, and dental care. And I personally, I can remember back being in residency, I've never seen a dentist until like the last month of residency. You just don't have time. But that's, as healthcare providers, that would be bad role modeling for our own patients. So these are the things that are coming this way. So integrated internships will be a very positive change. Curricula will be positively affected by reviewing data and our milestone data. Interactive and multimodality learning will enhance physicians' skills and knowledge. QI projects, or quality improvement projects, will set the stage for improving patient care and a culture of safety. and new wellness mandates, physician wellness mandates will focus on increasing and modeling healthy habits. And that's